Good morning, everyone. At the outset, I would like to thank the organizers of this workshop for the opportunity to present before you. The objectives of our presentation are to discuss the role of pre-procedural imaging, recognizing abnormal substrate on electroanatomical mapping, discuss a bit about the symbiotic use of entrainment and substrate mapping, and finally discuss the nuances for epicardial ablation. I hope to bring these out in this case that I would want to present before you right now. We have a 56-year-old male with normal coronaries whose status post ICD implant for sudden cardiac arrest, who presented to us with recurrent appropriate ICD shocks. Despite multiple medications, both singly and in combination, the episodes of ventricular arrhythmia were not controlled, and hence it was planned that he would be taken up for an ablation. Prior to the implant of the ICD, an MRI was performed, which had shown epicardial late gadolinium enhancement at the base of the LV, transmural at that location, apical LGE, along with lateral wall LGE in the base and the mid, which is also transmural. Occasional foci within the papillary muscle were also noted at that point in time. He had a normal PET scan prior to the implant of the ICD. At presentation right now, his ECG was a normal sinus rhythm with normal QRS duration, normal QTC, without any fractionation in any of the leads. The hardware that we plan to use for the process was mainly a decapolar catheter placed within the coronary sinus, the Tacticath force sensing catheter and HD advisor grid placed retrograde via the retrograde aortic route into the left ventricle for purposes of mapping and ablation, the right ventricular catheter for purposes of stimulation. We also, in anticipation of epicardial access, prepped the epigastrium for the same. We also reviewed the MRI for making sure that we had a good access into the pericardial space. VT was induced very easily by programmed stimulation. VT was monomorphic. Lead 1 was predominantly negative. 2, 3, and AVF were also negative. V1 was positive with a mid-cavitary transition, suggesting that the exit of this arrhythmia was on the lateral wall of the ventricle in the mid-cavity. The QS in the inferior leads was probably suggestive that it could perhaps be even on the epicardium. This was a hemodynamically stable VT, and hence activation mapping was proposed to be used for ablating the same. The endocardial activation map was then created using the HD grid, and there was a clustering of isochrones which was noted in the lateral inferior wall of the left ventricle. Some of the signals at this location were initially fragmented, but never preceding the presystolic part of the ventricular arrhythmia. Attempts at entraining at this site showed that the site was outside the circuit of the VT, but the fusion was concealed, suggesting that these were mainly bystander sites. Many such sites were present during our mapping and were mainly clustered around these regions of the left ventricle. Given that we weren't able to get signals which were earlier in the cycle length of the ventricular arrhythmia, mainly within the diastolic corridor, we decided then to get epicardial access after reversing the heparin with protamine. Epicardial access was successfully achieved, after which we mapped the epicardium with the flexibility catheter. As you can see, there was some overlap between the areas of clustering of isochrone in the activation maps in the endocardial and the epicardial maps. Similar fragmented signals were noted in the epicardium also, overlying the endocardial clustering, and these were further earlier within the diastolic corridor than was achieved in the endocardial sites. Entrainment at some of these sites revealed concealed fusion along with the PPI TCL, which was within 30 milliseconds. The comparison of the activation and the voltage map in the endocardium and the epicardium suggested that at sites of clustering of isochrones, there was also lowered voltage noted. A sample of the signals that were found within the epicardial location, both in the early diastolic phase, in the mid-diastolic corridor, fragmented signals present in the mid-diastolic location, and also systolic location, suggested to us that perhaps the entirety of the circuit was contained within the epicardium. Prior to ablation, we performed a coronary angiogram and documented that the catheter locations for these signals were far away from the coronaries. Pacing for phrenic was done and no phrenic capture was present. We then began ablating at these sites when we noted that a change in the morphology of the tachycardia happened without any appreciable change in the cycle length, suggestive of an alternative exit from the circuit of the ventricular arrhythmia. We continued ablating at 30 watts with a lowered irrigation flow because we were in the epicardium, and finally terminated the arrhythmia with restoration of sinus rhythm. Post-ablation, there was non-inducibility of the arrhythmia when stimulating from 2 sites at 2 cycle lengths up to 3 extra stimuli. We closed our access sites in the groin with a figure-of-8 suture on the venous axis and reversed the heparin and pulled out the sheaths for the arterial axis. The epicardial sheath was removed after we confirmed no bleeding or collection of fluids. Glucocorticoids and lidocaine were instilled in the pericardium. Pain relief was given with colchicine as required, and the patient was anticoagulated post-procedure for a period of a month. In summary, therefore, when a patient with recurrent ICD shocks presents with no apparent VT morphology, it's useful to induce the VT at the beginning of the case for template purposes. Use the ECG at that time and the pre-procedural imaging to assess for possible sites of the exit of the ventricular arrhythmia. The presence of QS in the VT in the inferior leads in NICM may be suggestive of an epicardial exit site. It is critical, however, to map the endocardium well because the circuit may actually be within the endocardium and may preclude epicardial access. Imaging to aid the assessment of epicardial access, both pre-procedure and intra-procedure, is critical. Multiple exits may be possible for the ventricular arrhythmia from one single central substrate, and transection of the circuit isthmus is critical to achieve durable freedom from arrhythmia long term. Thank you for your patient hearing. I would love to take some questions.